So someone wanted to know, when should you think go to the hospital and be admitted because it's emergent when you have an acute double vision? Now, of course, the first thing you got to know is it binocular or monocular? And the way to figure that out is you have to ask the patient and then examine them. If you cover either eye, does it go away? Binocular. If they cover one or the other eye and it's still there, that is not an emergency. Acute monocular diplopia, that's like dry eye or some crazy thing in the front of the eye. That has nothing to do with me. So don't be admitting no monocular diplopias. Binocular. Now you have to know, is it up and down or is it side by side? So is it vertical or is it horizontal? If it's horizontal and it's an isolated cranial nerve, then you're talking about cranial nerve number 6. It could also be cranial nerve number 3, but they're going to have ptosis or anisocoria. It could be internuclear ophthalmoplegia. That's that medial rectus from the medial longitudinal fasciculus. If it's vertical, the 3 again, you're going to be looking for anisocoria and the pupil, and cranial nerve 4, which has no anisocoria and no pupil involvement and no ptosis. So which of these acute is dangerous? Internuclear ophthalmoplegia, that is medial longitudinal fasciculus. It's traveling from the nucleus of 6 to the nucleus of 3. That's in your brainstem. Admit. Cranial nerve 3. Admit. It doesn't matter whether it's partial palsy, partial pupil, half a third, all a third, 3/4 of a third. Third nerve palsy, dangerous. The pupil involved third, aneurysm until proven otherwise. So that what you're listening for is acute and painful. So if it's acute, painful, cranial nerve 3, pupil involved, for sure that's the aneurysm. You should watch that video. But if it's cranial nerve 3, pupil spared, acute and painful, you still have to admit that. 6, also dangerous, because that could be a localizing, a false localizing, or a non-localizing sign of increased intracranial pressure. So acute painful 6th, that's also needs to be examined. 4th would be extremely unlikely to be anything bad. However, if it's severe pain, you still have to work that out. So if you take away the pain and you have an acute 4th, but you have a cause, trauma, ischemia, you don't have to do anything with that. You could image them, but that could be outpatient. 3rd again, that has to be worked up. So who needs a workup in these cranial neuropathies? 3, yes. 4, probably not. 6, maybe, but probably yes. The key and differentiating feature, acute, painful, binocular. And you must test the lid, the pupil, and the motility, all 3. Because if you have 3 out of 3, lid, pupil, and motility, that's bad. That's for sure the 3rd. If it's just lid and motility, that could still be myasthenia gravis if you take away the pupil. Once you put the pupil in there, not myasthenia. Any combination of pupil and lid, also bad. Big pupil, big ptosis, big problem. That's 3rd nerve palsy until proven otherwise. Little pupil, little ptosis, also big problem. Acute painful, that's the Horner syndrome. You're worried about carotid dissection there. Little pupil, big ptosis, also big problem. That's still a 3rd. Little ptosis, big pupil, also big problem. That's still a 3rd. So 3 of them are 3rds. They're all bad. So acute, painful, binocular. Talk to the patient, examine them. But really, the only one you might be able to get away with is the 4th.